Hola, bona tarda a tots i a totes. En primer lloc, donar-vos les gràcies per connectar-vos a aquest webinar Accedeix al sistema de salut britànic, que està dins del cicle de seminaris de presentació del nou servei Expansió Digital Health and Medtech. Informar-vos que aquest seminari està finançat pels fons europeus a través del programa Enterprise Europe Network i seguidament em presento. Jo soc la Leire Alfonso, soc la consultora sènior d'estratègia internacional d'ACCIÓ, responsable del sector salut i ciències de la vida. Com sabeu, el mercat de la salut digital i els equipaments mèdics al món ha augmentat en els 2 últims anys i es preveu que creixi encara més, la qual cosa ofereix un ampli ventall d'oportunitats de negoci per a les empreses del sector a Catalunya. En concret, el Regne Unit és el principal exponent del sector de ciències de la vida a Europa, amb una facturació de 74.000 milions d'euros i a prop de 250.000 treballadors. El sistema de salut públic, el National Health Service, és un dels sistemes sanitaris més respectats del món i l'NHS cerca productes i serveis que siguin innovadors, beneficiosos, suportats amb evidència i que millorin l'eficiència del seu sistema. El govern britànic també col·labora amb la indústria a través de programes sectorials, on va invertir 192 bilions d'euros l'any passat. També el sector privat de la salut al Regne Unit, si bé és més reduït, representa un volum de negoci gens menyspreable d'aproximadament 10.000 milions d'euros. Per parlar més en profunditat sobre el sistema sanitari del Regne Unit, compartirem avui amb la participació de la consultora Southeast Health Technologies Alliance, de la mà del seu CEO, el senyor Neil Roberts, i del seu director, el senyor David Pavel, que ens donaran les claus sobre com accedir al mercat del healthcare britànic. Abans de la seva presentació, l'Òscar Martí, director de l'oficina exterior d'ACCIÓ a Londres, ens explicarà els detalls d'aquest nou servei Expansió Digital Health and Medtech. Finalment, obrirem un torn de preguntes per respondre a qualsevol dubte que us vagi sorgint. Abans d'introduir a l'Òscar, el primer ponent, us comento un parell de temes tècnics. En primer lloc, les dues presentacions seran publicades a partir de demà en un enllaç que compartirem amb vosaltres en el xat de Zoom. Informar-vos també que aquesta sessió està sent gravada i que la gravació també serà publicada al mateix enllaç a partir de demà. Comentar-vos que podeu anar fent les preguntes al xat de Q&A i que no espereu fins al final. Jo us animo a que aneu fent les preguntes a mesura que us vagin sorgint durant les presentacions. Podeu fer les preguntes directament en anglès quan vagin dirigit al David o al Neil i quan siguin relatives al servei cap a l'Òscar o cap a mi en castellà o en català. Sense més, i ara ja sí, per començar el seminari d'avui, cedeixo la paraula al meu company, l'Òscar Martí, director de l'oficina exterior de Londres. Endavant, Òscar.
Bona tarda, Leire, i bona tarda a tothom. Moltes gràcies. De fet, ara comentaves el tema aquest de les preguntes i veig que hi ha entrat una amb el que ens animem ràpid. Molt bé, doncs, com deia la Leire, soc l'Òscar Martí, director de l'oficina d'ACCIÓ a Londres, i és un plaer tenir l'ocasió d'estar-vos presentant aquest servei i exclusivament com l'estem enfocant en el cas del Regne Unit. Si us sembla, i molt ràpidament, perquè de fet ho hem estat explicant la setmana passada i al llarg d'aquestes sessions que estem fent també junt amb França i Alemanya estem passant a introduir el servei. En aquest sentit no m'estendré massa, perquè alguns de vosaltres ja ho heu sentit, els que esteu interessats en diversos mercats més d'una vegada, però sí que farem alguns matisos, potser, com us podeu imaginar, per mercat. Podem dir, d'alguna manera, que el servei comença avui, comença en el cas de Regne Unit. Doncs el 30 de març estem fent aquesta primera presentació que està finançant en aquest cas per l'EN i dona l'oportunitat a tothom, gràcies a la presentació que faran en David i en Neil, de conèixer millor, amb més detall, el que és l'oportunitat, el que són les necessitats, el que són també les dificultats d'accedir al mercat de la salut públic i privat del Regne Unit. Procedirem després d'aquesta presentació ben aviat ho veureu a les vostres bústies, les empreses interessades, en obrir aquesta convocatòria perquè us apunteu i llavors respondre i incideix en aquesta part del formulari que veieu en qüestió, perquè un cop tinguem ben clar els interessos de les empreses gràcies al contingut del formulari, serà possible per nosaltres fer aquesta selecció competitiva que farem de fins a 10 empreses per mercat. Us animem, i és molt important, com dic, ressalto, que incloeu el màxim d'informació possible en el formulari. Som conscients que tenim molta feina i potser fa una mica de mandra, però ens ajudarà no només a nosaltres i a CETA, que estarà també implicada en la selecció d'empreses, a poder escollir les que poden utilitzar millor aquest servei, però al mateix temps també poder recomanar i poder contactar amb aquelles que potser creiem que hi ha altres vies que siguin més adequades per a ells, d'acord? Amb el que en aquest sentit, quan de més informació podeu compartir, i hem fet un formulari que serveix per 3 mercats per aquelles empreses que esteu buscant més d'un mercat, doncs sí que això, animar-vos a que ens doneu tota la informació possible. Seguidament passarem al que ja seria amb aquestes empreses que han estat seleccionades la primera fase del programa, aquesta fase d'assessorament estratègic, que s'iniciarà amb un treball en grup amb aquestes empreses, unes presentacions i sessions, primer de caire grupal, per entrar més en detall, com una segona part, diguem, del que ens introduiran avui els companys de CETA, sobre Digital Health i Medtech en particular, aspectes importants per a aquestes empreses ja d'una forma més específica per accedir al mercat. A partir d'aquí ja tractarem de forma individual cada empresa amb unes reunions d'assessorament especialitzat, de les quals tingueu en compte que, òbviament, estarem també des de l'equip d'Acció amb suport en aquestes sessions grupals individuals, però a través, com deia, de les quals arribarem a un informe de recomanacions o que, en el cas específic del Regne Unit, el que busquem aquí és també tenir una mica el resum del que haurem treballat. És a dir, que tinguem ben clar quina és aquesta ruta d'entrada al mercat. Si, per exemple, estem parlant que hem d'aconseguir primer aconseguir l'evidència que el servei, el producte funciona, com sabeu que és important. I això ho hem de fer amb algun tipus d'assaig clínic, amb algunes de les entitats que us podem presentar. O potser necessitem algun tema regulatori, potser necessitem algun tipus de modificació. Entrar tot això, tenir-ho ben clar, i a partir d'aquí veure també, un cop entrem al mercat, quines expectatives hem de tenir a nivell de temps, a nivell també potser d'inversió, a nivell de perfil d'empresa amb la que hem de comptar. I aquí és on ja entrem amb aquesta fase 2, que li podem dir d'accés al mercat, o li diria d'execució, si voleu, amb el qual ja tindrem prèviament ben definit si hem d'anar directament a client final, si hem d'anar via distribuïdors, si són distribuïdors de quin perfil, quin àmbit explícit hauria de ser aquest distribuïdor. Tot això és el que hem aconseguit en aquesta fase inicial i que llavors buscarem en aquesta segona fase, així com tot el suport de part de l'oficina d'Acció també per possibles participacions en esdeveniments o desplaçaments al mercat en particular que puguin ser útils. No és un camí, i no dic res de nou, que sigui senzill, és un camí que òbviament s'ha de treballar, és un sector especialment competitiu i, com tothom bé sap, amb àmbits regulatoris i aspectes regulatoris i aspectes del mercat en si que poden ser molt ardus en segons quines ocasions, amb el qual busquem que hi hagi tot petit element en el qual podem ajudar. Dit això, com sabeu, comptem amb aquest servei suport d'aquestes consultores especialitzades. En el cas del Regne Unit és CETA. Jo mateix ja vaig fer una petita presentació de CETA en la presentació inicial del servei la setmana passada. No crec que sigui molt necessari avui perquè en David mateix i en Neil us faran una petita visió general al principi de l'organització de CETA abans de procedir a la presentació del mercat. A qui ens dirigim amb aquest servei? Com sabeu, empreses de l'àmbit de la salut digital i de les tecnologies mèdiques. Principalment, ressaltar que busquem empreses que tinguin si pot ser de forma ideal, algun producte ja, diguem-ne, que s'està comercialitzant, que tenen clients i, diguem-ne, que ha d'haver un recorregut d'aquesta empresa. No tenim el servei tan pensat com per a empreses que comencen de zero, per això hi haurien altres possibilitats. En aquest cas, el que busquem és una empresa que, com diem, tingui cert històric per poder, a partir d'aquí, fer els passos que estàvem explicant a la fase 1 i a la fase 2. Tot i així, ressaltar que, òbviament, valorem totes les sol·licituds. Poden haver casos molt particulars en els quals veiem algun servei especialment, servei producte especialment innovador, amb el que, en aquest sentit, sí que convidar a tothom que creu que té la capacitat i la projecció per estar en un mercat com el del Regne Unit a fer la sol·licitud i, òbviament, l'avaluarem i es donarà tot el feedback possible. A nivell de característiques també d'aquest servei d'expansió que hem definit, comentar que no està pensat per accedir directament a la fase 2, com deia, més d'execució, més de contactes comercials, sinó que la idea és que es passi per dues fases. Per aquelles empreses que creuen que ja estan perfectament capacitades per anar directament a la segona fase de mercat, tenim altres serveis que estarem encantats de discutir. La fase 1 i 2 no han de ser necessàriament consecutives. Això és important. Com estava dient al principi, poden haver aspectes que s'han de corregir, que són els que identificarem a la fase 1, aspectes que s'han d'afegir elements, s'han de fer alguns passos previs abans de fer aquesta segona part més comercial, amb el qual entre la fase 1 i la fase 2 pot haver també un temps d'espera, òbviament sempre que això és el que tingui sentit per l'empresa catalana. I dir també que si hi ha alguns d'aquests passos, diguem-ne, previs a l'aspecte comercial en els quals l'oficina els pot ajudar, doncs no hi hauria tampoc cap inconvenient. De fet, el que és la fase 2, crec que m'he deixat de comentar-ho ara fa uns minuts, preveiem fins a 80 hores de dedicació dins del marc del programa. Després hi haurà diferents opcions si fos necessari més temps, però dins d'aquest servei que hem definit, comptem fins a 80 hores de dedicació des de l'oficina d'ACCIÓ a Londres. Dir-vos també en aquest sentit, ja seguint lligats amb les oficines exteriors que estem involucrats al llarg de tot el servei, des de, com deia, en les reunions inicials que també farem amb els consultors, sempre l'empresa comptarà amb una persona basada a l'oficina d'ACCIÓ a Londres donant suport i, òbviament, també en aquesta part on ACCIÓ estarà especialment implicada de contactes comercials que avançàvem a la fase 2. Finalment, també ressaltar que el que és despeses de viatge, organització, són costos que, com és d'imaginar, van a part, poden anar relacionats amb el programa, però no quedarien inclosos dins del cost que aquest té. Referint-nos llavors al cost, com veieu, gràcies a la bonificació que sol oferir ACCIÓ pels seus serveis, com pel descompte addicional que s'està duent a terme ara mateix per pal·liar alguns dels efectes de la greu situació de conflicte bèl·lic que tenim a Ucraïna, disposem d'un cost especialment interessant també pel que és el servei. Segurament podríem parlar de que, com diria el Regne Unit, value for money. Segurament l'empresa catalana mateix dins d'aquest àmbit és difícil de trobar un servei que ofereixi més valor que el que hem dissenyat. Com veieu, en el cas del Regne Unit i així com en els altres mercats estem parlant al voltant de 1.000 euros de cost per l'empresa, que inclou les sessions que havíem comentat a la fase 1 i les fins a 80 hores de consultoria a la que em referia abans, que és el suport que es dona des de l'oficina d'ACCIÓ a Londres per la fase 2 de mercat. Finalment, només agrair a totes les entitats que també han fet això possible, amb les que ens ha encantat compartir les idees d'aquest servei, recollir les seves recomanacions i estar sempre comptant amb elles de cara a la promoció del servei i al disseny mateix d'aquest servei en el qual tenim molta confiança i moltes ganes de dur-lo a terme. Moltes gràcies.
Gràcies, Òscar. And now I pass the floor to Neil Roberts and David Parry from SETA. Thank you very much for your collaboration. It's a pleasure to come with your participation in this webinar, and the screen is yours.
Well, thank you very much. It's a pleasure to be with you all this afternoon. Thank you to Catalonia Trade and Investment for inviting us to be part of this exciting project. And I hope we'll get to know some of you a lot better over the coming months. So my name's David Parry. I was the Chief Executive of the South East Health Technologies Alliance until last year. I did that job for 15 years, and I still work with the organization, and I'm still a director. So first of all, a little bit about the South East Health Technologies Alliance, SETA. We have been around since 2005. Our aim is to develop relationships between universities, clinicians, particularly those in the NHS, and small companies like yourselves. We are a not-for-profit membership support network, and we have over 1,400 members, a lot of them in the UK, although we do have members from over 20 countries, and we would invite you to join because it is free to join. What we do is provide various levels of support. We provide one-to-many support by organizing events and participating in webinars like today, but we do one-to-one support as well. My background is research, and I am an assessor for the government for research proposals. So we help companies understand the research landscape. Neil's background is much more commercial. So we help companies understand how they develop a commercialization strategy for the UK. And Neil and I do a lot of mentoring. We do a lot of mentoring for UK and overseas companies. Over the past 5 years, I think we've done mentoring for over 500 companies, helping them understand and access the UK markets. But we also work with NHS trusts. We work quite closely sometimes with chief executives to find out what they need, and we help them sort out their problems. So that's SETA. Next slide, please, Claire. That's where we sit. We sit in the middle of the A, B, C. And as you can imagine, if you've had any dealings with universities and clinicians, they sometimes pull you in different directions. And it's our job to try and find the sweet spot and bring people together for everybody's benefit. Next slide, please. As I said, we would welcome companies from Catalonia. I think actually we've got some already, but we'd welcome more. So please do join if you feel able. Next slide, please. We're going to be talking mainly about the NHS this afternoon, and we have produced 2 guides in the last few years, which I would recommend that you get hold of. Claire has got details. We can tell you about them. They are both designed for small companies who want to understand and access the NHS in the UK. 2 guides. Talk to Claire if you need to know more details. Next slide, please, Claire. I'm going to be taking some of the data from those guides, and I'm going to be challenging you with some of the data. So here are some of the data about the NHS. It's in the top 10 employers in the world. It employs around 1.5 million staff, 100,000 doctors, 300,000 nurses, lots of technical staff and science staff. Don't forget that. It's not just doctors and nurses. There's lots of technical staff in the NHS, midwives, ambulance staff, and lots of managers. These might be key people for you to think about. There are lots of managers as well as clinicians in the NHS. Next slide, please. So I'm just going to describe where we are at the moment in the UK. We have, like many European countries, the perfect storm. I'll say a little bit then about the structure of the NHS. Not too much because it's very complicated, but all the slides will be available to you if you want to see any more detail. A little bit about how well we're performing, but I want to focus particularly on drivers, macro drivers and micro drivers. These are important things you should consider when you're trying to sell into the NHS. So a little bit about the importance of having a clinical champion. You need a clinical champion. But then I will also very briefly talk to you about the private healthcare market. There is a private healthcare market in this country. It consists of a privatized, if you like, health service, but it also consists of a privatized care service. And then we'll have some brief conclusions at the end. So that's what I'm going to be doing. And I think, like many countries at the moment, we are finding the perfect storm. Interestingly, I think in the UK, although we've had some really hot weather, I think there is snow forecast for tomorrow, which is a rather strange thing to be happening at this time of year. But this is a slightly more metaphorical storm. Next slide, please. And it starts really with the aging population. You have this in Catalonia. We have this across Europe, really. It's the simple fact we're living longer. We're living longer. And that skews the population. So I think one of the most important facts there is the number of over 85s, because almost every over 85-year-old needs some health and care support. And that is increasing from 1.5 to 3.6 million. And I'm sure it's the same in Catalonia and across Europe. 70% of the health and care budget is spent on looking after the elderly. It's a fact. So the more elderly we have, the bigger that spend is. And in this country, and we'll talk about social care a little bit, there is a constraint on looking after people in a social care context. And I'll say more about that later. But the problem we have in the perfect storm, particularly in the UK, is that, we demand health services to be free, and the demands seem to be infinite. People expect the government, the state, to provide for their health needs, and these needs are increasing, and they are costing the taxpayer more and more. And of course, if you want to put the icing on the cake of that perfect storm, or a lightning bolt through it, like Spain and Catalonia, we have had to deal with COVID, and that has really messed things up in health and care. So a perfect storm, how are we going to deal with it? Next slide, please. Well, is the structure of the NHS going to deal with it? Perhaps. Let's have a look at the current structure. Please don't worry about this too much. And I would, if you are interested, I would ask you to look and Google a website with the King's Fund. In the UK, there's an organization called the King's Fund. You can see that on the top left, that does a lot of drawings and documents about the structure and the function of the NHS. I would warmly recommend you have a look at them. But I will just go through this very briefly to give you the overall context of the UK NHS. First of all, the Treasury, the taxpayer, has to fund this through the Department of Health and Social Care, and it has roughly around £130 billion a year to spend. It spends a certain amount on capital, new hospitals, refurbishment. It spends some on social care, but the vast majority goes to an organisation called NHS England, which is spent on hospitals, patients, doctors, through clinical commissioning groups at the moment. I won't say any more about that because, unfortunately, as you will see, the structure is changing, and it's changing quite dramatically. It seems that whenever the politicians get involved, they want to change the structure. Next slide, please. And again, a little bit more data from the King's Fund about how the National Health Service is regulated and commissioned. It's regulated and commissioned at a national level by two organisations, NHS England, NHS Improvement, and the Care Quality Commission, and a regional level by regional teams. Now, actually, this is changing. So until recently, the big players in commissioning health and care were things called clinical commissioning groups, CCGs. They are changing. They are moving into something else. In fact, they're moving into things called sustainability and transformation partnerships, which are then evolving into integrated care systems. And I'll say a bit more about that in the next slide. Next slide, please. before we look at structure, you know, the structure of the NHS has got to cope with facts like this. You know, the UK, like many European countries, has got a big problem with obesity. I mean, look at those figures, 67% of men clinically obese and 60% of women. And of course, you know, obesity and diabetes are linked, obesity and lots of other diseases are linked. And we find that obesity is a significant factor in almost 1 million hospital admissions. So we've got a very complex system, and it's got to deal with some very, very big population-wide problems. Next slide, please. So back to the structure. I mentioned clinical commissioning groups. These are disappearing. They are disappearing by law this year. We think it was meant to be happening in April. I think it might be happening in July now. They were evolving into the next level, which are called sustainability and transformation partnerships. We'll skip those because they are evolving into the next level, which are called integrated care systems or integrated care partnerships, which are geographically confined, and they are run by integrated care boards. And interestingly, what's happening there is that finally, the government has recognized that we should be looking at person-centered care. So instead of saying somebody is sick, they need a hospital, or somebody has got dementia, they need care, what we're saying is everybody should sit around a table in health and care and say, what does that person need? Let's put our budgets together and actually provide for that individual, irrespective of whether it's a health or a social care need. This is a great move forwards. These are called integrated care partnerships, integrated care boards, and we are all hoping that they can work. But still, the people you're likely to be talking to most are NHS trusts. So these are hospitals, specialists and general hospitals, around 135 district hospitals and some specialist hospitals. And of course, the first port of call for most people in the health system is the general practice doctor. There are around 8,000 general practice doctors, which are now becoming organized into networks to serve the integrated care partnerships. So they're grouping together. And there are also some specialist services, which you may or may not be interested. So you can see it's quite complicated. It's evolving. I think we all agree it is moving in the right direction towards person-centered care. This is an opportunity for you guys, because if you can understand how you can help an integrated care partnership, put all those services and support together, then you're in with a chance of doing some business. Next slide, please. That's the bottom line. In fact, I was doing a talk last week where a senior NHS official told me it's not 1 million patients every 36 hours. It's 1 million patients every 24 hours now. Imagine having to deal with that. Next slide, please. And that's what most people look at the NHS and think it is. It's a complicated bundle of wires, and you pull one and nothing happens, or it's connected to another. It is a complicated system, no doubt. Next slide, please. And, you know, arguably, are we doing well? We spend around 10%. It's gone up since COVID, around 11% perhaps. EU averages around 12%. The US spends 17%, but the US is not doing that well on health outcomes. But most of our hospitals are failing in waiting times, and a lot of them are overspending. And of course, that's partly to do with the COVID pandemic that we've all been having to manage with. So are we performing well? It's up for debate, really. Next slide, please. Except that the waiting lists have gone through the roof. And that's another important potential business opportunity. If you can find something that can reduce those waiting lists, you're in with a shout of a sale. Next slide, please. So what are the big drivers? What are the big drivers? How can you actually get to grips with the NHS as a small company thinking about this as a market? Well, of course, population, aging population, long-term conditions. If you've got something there, that is of interest, because we have to deal with aging people who have more long-term conditions. Price, 80% of that 130 billion or 120, depending where you pitch, is spent on people. Can you do something? Can you bring something in that helps improve efficiency? And of course, new therapeutics and new technology is expensive. We need value for money. Have you got value for money? You need to look at the politics. The NHS is as close to a religion as we have now in the UK, and there are some big, powerful organizations that have got vested interests. Every clinical discipline is represented by a royal college. So you'll have the Royal College of Surgeons or psychiatrists or whatever. They are a very powerful union. They defend their territory and their salaries. And of course, it is completely wrapped up in politics. It's an enormous spend for the government. It's the biggest spend now. It's above pensions. It's an enormous spend. So any changes in salaries can affect the national treasury significantly. And of course, clinicians don't like being told what to do. Clinicians are some of the brightest people that we have in the country. They don't like politicians very much. They don't like managers very often, and they don't like being told what to do. So, we've got an interesting dynamic going on there, really, politically. And again, a big driver for the whole clinical health and care system over the last couple of years has been COVID. How we cope with that? Well, there we are. So some big drivers there. Let's have a look at some smaller ones. These are important. These are important because let's not forget, the bottom line is we are dealing with people. We've got complicated systems, but your interface will be with an individual or a group of individuals. Now, the chief executive of a hospital, an NHS trust in the past, could lose their job if they overspent their budget. Nowadays, they can lose their job mainly because of bad publicity, because of safety problems. And we are very open in the UK, or as open as we possibly can be, about when things go wrong. Literally today, there's been a massive report announced by the government in all the newspapers about maternity services in a county in the UK. And it's been terrible. The service has been terrible. So if you are the chief executive of one of those hospitals and you've had a bad safety record, you'll lose your job. The NHS now is increasingly being sued by people. So if you've got something which can actually reduce the risk of a lawsuit, improve safety, reduce the risk of bad publicity, you're in with a shout. Think about the people you're dealing with in terms of senior managers, because you may not deal with the chief exec, you may deal with a senior manager. They are judged on performance. If you've got something that can actually increase their performance, get more patients through more cheaply, more effectively, you're in with a chance. Finance directors are only interested in budget. You will have to present some sort of budget analysis for your innovation. The finance director will be convinced it's worthwhile if you can demonstrate to him or her that it will save money, preferably in that financial year. I know that's very difficult, but certainly in a year or two, save money, the bottom line. Clinicians, obviously their priority is patients, but they are people. They are people with a career, a reputation. And if you've got something that will enhance their career, allow them to be the first to have this new technology, to publish the papers, to actually speak on the conference platforms, they'll be interested in what you've got. And of course, if you need to, you may have to pay them, even though they're employed by the NHS. Most NHS clinicians work in the private sector. There's nothing stopping them doing a day a week for you if they so want. Next slide, please. It is very important if you want to get into the UK health and care market, into the NHS, to have somebody who believes in what you do. You've got to get a clinician. Clinicians talk to clinicians. Get one if you possibly can. And those are some ideas as to how you might get them. But don't give up. You really do need a clinical champion in the UK. If you've got one in Catalonia, get them to find one for you in the UK. Next slide, please. Well, there we are. Some facts again about the number of beds. Is it good that we have fewer beds or more beds? Arguably, we should have fewer beds because we don't need hospitals, because we're looking after our people, our population better outside, because who wants to go to hospitals? Interesting, really. Is it good to have lots or few? It's almost a philosophical point. Next slide, please. So, summary, selling to the NHS. These are some of the basic elements that you have to consider. You have to have the evidence. You have to have regulatory approval if you want to sell to the NHS, unless you're on a research track where you can do some pilots under license. So it does help if you've got a clinical champion working with you to show it works and got the evidence. You've got to understand the customer. Neil will talk about, the ecosystem that we're talking about now, but, you've got to understand the clinician you're dealing with or the manager you want to deal with. Understand what ticks their box, what will get them excited. Yeah. And you have to have a financial case. You have to describe what it's worth. You have to do some sort of basic cost benefit or budget impact analysis to show the finance people that it will save money. Yeah, so that's a summary. You have to tick all the boxes. So let's move on to the private health market. So we've done the NHS. In the UK as well, you can pay for treatment. You don't have to go to the NHS. And it's worth a significant amount, around 10 billion a year. So it's either funded by insurance, so you can buy an insurance policy, you pay into every year, and if you get sick, you can claim on that insurance policy and get treatment. So we've got some of the big insurance players there that I'm sure you've heard of. Alternatively, you can just pay a hospital directly. So if you've got a bad hip that needs replacing, you can go to a private hospital or even an NHS hospital, which has private wards, and say, I need a hip replacement. How much do you charge? It's usually about £15,000, and you can pay for it and get it done. So, there is a market there, and it seems to be a growing market, because actually the NHS is now contracting with some of these private hospitals and private clinicians to try and reduce the waiting time. We're in such a mess with waiting times. And please don't forget that most private clinicians are also NHS employees. It's a complicated situation, but most NHS doctors actually work in the private sector as well. They're allowed to do that. So it might be one way in for you and your technology is to try and get it adopted by the private sector, where they might have a little bit more cash to spare. And if that clinician thinks it's good, he or she might want to take it into the NHS. Next slide, please. So that was the private health sector. This is the private care sector. Okay, so the health, we see 140 billion a year. That's the NHS purse. It's a lot of money, but there is a social care private sector. Currently, it's actually managed and run by local authorities, and I don't think there's any reason why that will change. But the care sector in this country really consists of looking after people in their own homes. We call that domiciliary care, or looking after people in care homes or nursing homes. Day centres a little, but the main market is domiciliary care and care and nursing homes. And it's a big budget. And the local authorities will not pay very much for this. They spend the money, but a lot of this has to be paid for by individuals. So let's look at that a little bit more. Next slide, please. This is a big and growing market. As we said at the very beginning, part of the perfect storm is that people are getting older. they're living longer, and they need more care. 500,000 people now in the UK are in residential care, 24-hour-a-day care. Of 16% of over 85s have to be looked after 24 hours a day. And those numbers are growing. The costs are increasing. This is an expensive endeavour. It costs over £1,000 a week, over £50,000 a year to look after an individual, one person, in a nursing home. And there is less public sector funding available. So we have a problem. Next slide, please. But with a problem, there's an opportunity. This care market is worth a lot of money, 17 billion. And something that you should know is that most care homes and nursing homes and domiciliary care providers are in the private sector, over 95%. This is a privately owned business, yeah? And there are around 15,000 nursing and care homes. It's a fragmented market. There are some big players. You can see them listed there, but they only run about 15% of the market. The rest, 85%, are smaller operators. But it is an opportunity. The owner or manager of a care home can decide to buy your technology like that. No procurement, minimum regulations. I mean, obviously, it's got to have a CE mark or something. But nonetheless, they can buy your technology and have it in tomorrow. Don't have to worry about public sector procurement. So this is an interesting opportunity. Next slide, please. Just to delve into it a little bit more for you, this whole care sector is regulated by a thing called the Care Quality Commission. And this is important when you're thinking about selling. So it's inspected by them. They'll get a rating, and you have to provide some information to them. So they will rate your nursing or care home as inadequate, requires improvement, good, or outstanding. That will be publicly available on their website and on your website. So, you know, everybody wants a good or an outstanding rating. Yeah, it's a competitive marketplace. And we in SATA believe passionately that the innovation out there could improve the efficiency and effectiveness of care tremendously. But we also recognize it can't replace people. So it's an interesting one, an interesting potential market. Next one, please. We've done some work into this. These are some of the things where we think technology could help in nursing and care homes. I won't go into them in detail. You can see things like falls. Falls is a big problem. But routine tasks like admin tasks, location tracking, risk assessments, hydration and nutrition, important things in care homes to make sure you're on top of. Is there technology which could help to do that? So these are some of the areas where we think technology could find a market. Next slide, please. And, you know, the factors that influence a purchase in the care sector are different to those that might influence a purchase in the NHS. The care sector really are improving resource efficiency. Actually, that means, can I employ fewer staff, or can I employ those staff more effectively? Yeah, so reduce my wage bill. Can I actually improve rates of referrals? This is a competitive market. Are people wanting to come to my care home because we have got the best support, technology? Our CQC rating has moved from good to outstanding because we're very good at what we do. We've used technology to improve efficiency and effectiveness. Can you actually provide some technology which will reduce the insurance bill? The insurance bills in the care sector are enormous because of the risks. Have you got some technology that might reduce the risks of looking after people in the care sector? If you have, they would be interested. These are three areas. If you've got technology where you could improve resource efficiency, improve rates of referrals, reduce insurance, care owners will buy. Next slide, please. So just to conclude, the UK is an interesting marketplace for your product, particularly, I think now, particularly for small companies, because we're going through massive change. We're massive change in terms of structure, We've got waiting times, we've got COVID to contend with, and it's an opportunity. You are well placed. And I do passionately believe that technology will provide some of the solutions. Please don't forget the care sector. It's an important and growing sector for technology, devices, digital and diagnostics. Don't forget, if you want to focus on the NHS, you need a clinical champion and you need clinical evidence. You need some cost benefit analysis. Next slide, please. I think that's me. Look at that, bang on time.
Thank you, David. So thanks very much for outlining the structure, organisation, the key drivers to selling to the NHS and private sector, and some of the opportunities that represents. What I'd like to do, I'd like to extend that, and I'd like to look in some more detail at the healthcare system as an ecosystem. I'd like to talk more about procurement in the sense of historically about procurement, but also about and most importantly, about new initiatives that have taken place in respect, particularly to NHS procurement. And then importantly, for the majority of us who are developing new innovative technologies, to look at the processes associated with the adoption of innovation. Now, I'd like to do that in a highly practical and clear way. And to do that, I'll be drawing on more than 25 years worth of experience selling directly to the NHS and private sector here in the UK. So let's start really by challenging what many of us consider a binary view of the market. That's us as suppliers, supplying directly to customers. That's us as suppliers having to deal with and considering competition, because I think the actual market is way more complex than that. And when we add the extra layer of the digital healthcare ecosystem, then we see that as a system, it is highly complex. A lot of people doing a lot of different things. David's highlighted some of the ways that they're organized, some of the services that they deliver. And when you look at how they relate to a supplier base, that is also complex. And we really need to understand our position in respect to that. So we need to understand that there are dominant suppliers in the marketplace. If we look at the digital healthcare ecosystem, then we can quote perhaps Cerner or Epic as dominant suppliers in that sector. And there are initiatives that have been taken by NHS trusts around policies Cerner first or Epic first, originated with a cloud first policy translating into policies such as Cerner first, where more or less all procurement, all access related to digital services is funneled through Cerner or Epic as the primary suppliers. So we've got to work out what it is that's missing, what it is that those dominant suppliers can't provide, and we can provide in partnership with them. Generally, the NHS is risk averse. So by working in partnership and collaboration, we'll be able to de-risk our proposition and we'll be able to access that market more successfully. So that's the first point, I think, to note, that we can access the NHS more successfully through collaborations and partnerships rather than an unknown or very new entrant into the marketplace itself. What we also need to consider is that it's not only about the product. I think as developers and suppliers of product, we're often so involved with the product itself that we struggle to see beyond that. But many failures in accessing the NHS hinge around dealing with legacy product, what already exists, and the degree to which that can be utilized, and how we manage a transition from a legacy product to a new product. How we support users of the product, how we train them and how we support them. Because many things that are new to people and alien to them, they have some resistance to the adoption of those technologies. So we've really got to think through our implementation plans to the point where we've audited exactly what's being used, we've assigned a useful life to what's being used, and we're managing the whole process of replacement and implementation through support of staff and consistently providing that support to staff to enable a successful implementation overall. So don't just think about the product itself and the benefits, the value proposition associated with that, but think how you're actually going to manage the implementation of that product into that complex ecosystem. Next slide, please. So again, wanting to be practical in our guidance and clear in our guidance, wanted to really cite here some examples of likes and dislikes at that C level, that chief executive level within our hospital. So one of the things that's a definite dislike is any type of pay per use. Many hospitals have been burnt and have seen a failure in a pay per use type approach. It's been difficult for them to understand. There's been arguments about the degree of utilization. And so what we have on screen here are the preferences that exist now within the NHS, from try and buy, so the supplier taking the risk, placing a product, supporting the use of that product, and if the customer likes the product, then ultimately they will buy it, all the way through to standard outright capital purchase. And of course, those models that you would be familiar with, like software as a system, offering a product with multiple features and maybe offering it in an early iteration with the ability to develop the functionality and features over time. The other point of guidance from this slide is if we only present outright capital purchase as an option, then there's a 50% chance that they'll say no, because the alternative is that they don't buy. So to have as many options as possible diminishes the chances of them turning around and declining the offer, declining the opportunity to proceed. So very important that you offer a range of purchase options to both the NHS and the private sector. When we ran focus groups asking for preferences in purchase amongst NHS purchasers, they all said that having a range to suit their capital requirements at any particular time was particularly attractive from a supplier. Next slide, please. So let's just provide ourselves with a reminder in respect to NHS procurement. As David intimated from his King's Fund slide, procurement of general supplies and medical equipment by the NHS, around £6 billion per annum, accounting for about 4% of the NHS budget. And what we know as a characteristic during this time of austerity is that capital applications way outstrip the amount of capital that is available. So back to David's point about finding a champion within the purchaser to be able to drive the demand for your product from an internal perspective and get that capital application higher up that priority list is absolutely a key to success. And again, as David alluded to, making sure that you've done some kind of health economic modeling and there is a health economic advantage, a cost effectiveness advantage to purchasing your product. Next slide, please. So here we have the core principles of procurement, and David's alluded to a couple of these, and let's distill them down into very simple questions. So formatively, does it work? What evidence do we have of efficacy? How well does it work? Is it safe? So does it comply fully with the required standards? And as we've seen, the standards are becoming more complex. Now we've moved on with our exit from the European Union from CE marking and the MDD, MDR transition, IVD to IVDR transition, and we now have our own standard UK CA, which from June 2023 suppliers will have to comply with. So now is the time to be considering, whilst we have the grandfather rights under CE, as how we're going to apply for and secure the all-important UK CA mark. But there are other standards to consider as well when it comes to digital health technologies. There's the so-called DTAC, Digital Technology Assessment Criteria, which now apply, and it's indicated that will become a mandatory part of digital technology procurement. And there are all sorts of standards related to data protection, security, and so on, which we must consider. And then, of course, how does the product compare against competition? Because you're not going to be alone out there in the market. The clinicians will be doing something, and you may challenge that, and you may have an innovative approach and a far better approach, or you may be selling against direct competition. But you really need to understand how your product compares to what is currently being done and the pathway that's been undertaken, and how your technology may affect that pathway. And then just to reiterate what we've said, because this is public spending, there's now a requirement to be able to demonstrate an economic advantage to the procurement of your solution. How does it save money, and over what time period does it save money would be a simple demonstration of how cost effective it is. Next slide, please. So just looking at what's relevant in terms of the historical elements to procurement. Well, I imagine, as in Catalonia, anything that involves public spending requires some form of tendering process to ensure that we're applying a fair and even-handed process to procurement. And historically, the UK has been so and continues to be so. But in its early iteration, procurement was administered by the hospitals themselves, engaging procurement staff at relatively high cost to the organization, and operating through an organization known as the Purchasing and Supplies Authority. We abbreviate everything, provide acronyms, so the so-called PASA organization, which was a fairly unfriendly organization, difficult to approach, difficult to access. And then, of course, our membership of the European Union meant that we had to apply the strict EU tendering requirements for all of public procurement, which means that we had to advertise those procurement requirements in the official journal of the European Union. But how have we moved on since? Next slide, please. So probably the biggest initiative that took place, and it's now some 15 years established, was the establishment of the NHS supply chain. And essentially, the NHS contracted out to DHL, the logistics provider, and came up with an agreement whereby if DHL, as NHS Supply Chain, undertook all procurement procedure on behalf of the NHS, then the what's in it for them would be a percentage on the cost savings that they would generate by being a central purchasing organization. The advantage to the hospitals was that they didn't need all of the procurement staff that they had, that they were able to meet all of the tendering requirements with a much more streamlined process, which was encapsulated in what are known as framework agreements. So essentially, suppliers will tender for an anticipated requirement within the NHS, and they will provide all of their pricing details, product details against that anticipated demand, go through a formal tendering process, and then they, amongst many other suppliers meeting the tendering criteria, will gain a position on a framework agreement against which the NHS as individual trusts can then go ahead and purchase without undertaking a tendering process themselves. So it was really with thoughts of aggregating purchases that the NHS supply chain was set up, and the framework agreements were intended to deliver quite substantive savings against that procurement. Other initiatives that have come into being have been nationally contracted products. So where there's a relatively small but often high value demand, then they can be aggregated and then they can be centrally purchased and then distributed amongst the NHS as required. There's also the scheme in association with high cost tariff excluded devices. So where the cost of the devices would create a disproportionate cost to the nationally agreed tariff costs, then again, there companies can apply for status on the high cost tariff excluded devices list and provide them directly through NHS England. And we've hinted here a little bit at the national tariff payment system, but by adopting a standardized costing approach to procedures, it means that if you're able to contribute a saving towards that, then that's a direct cost saving to the hospitals themselves, and that's opened up a whole wealth of opportunities to suppliers to supply by being able to reduce the cost to the hospital within that national tariff payment system. Next slide, please. So if we look at what that means in reality, then we can see on the left side of the graphic, the NHS supply chain, and then how all of procurement is administered through the various categories. And the categories are aggregated into those that are medical, those that are principally capital, usually high cost capital related, those that are non-medical, and as you would expect, things like office equipment, food, hotel services, all make up the categories within non-medical. And then there are the support services that are provided directly by the NHS supply chain. Now, unlike the Purchasing and Supplies Authority, PASA, NHS supply chain are a friendly organisation. So the guidance here would be that you determine which of those categories applies to your particular product, and then via the internet, and all of this information is freely available on the internet, plus contacts, telephone numbers, emails, names. You can contact the NHS supply chain directly and inquire as to the status of framework agreements that apply to those particular relevant categories for product procurement. One of the disadvantages of the framework arrangement is that you tender at a point in time, and then those framework agreements apply for a period of time, could be anything from 3 to 5 years. And it's extremely difficult to obtain a place on that framework in that interim period. We'll come on to look how, particularly for digital health technologies with rapid iteration of product, that's been improved, but it is a cited disadvantage that if you miss the opportunity to tender for one of the frameworks, you may well be excluded from supply through framework agreements for anything between a 3 and 5 year period. But you will find that the NHS supply chain are an extremely friendly, helpful organisation, and I recommend, having found the appropriate category, that you approach them directly and deal with them directly. Next slide, please. So pre-pandemic, the government, the Department of Health and Social Care, really wanted to understand how well this initiative was working. So we've said been established for some 15 years to date. So at this time, maybe 12 years or so. And so they commissioned Lord Carter, who's had a successful career in healthcare and has also undertaken reviews of services like pathology, where there has been a crisis in resourcing. And under his guidance and under his chairmanship, a number of recommendations have been made in respect to how to improve pathology services, which are now being implemented and showing good signs of success. So in the same way, he was approached to set up a group to report on the efficacy, the effectiveness of procurement under the NHS supply chain. And the report identified, and we've got them listed here, that there were opportunities for improvement in procurement efficiency. They were dealing with an extraordinary number of product lines, some 600,000. There was certainly quite wide variations in product prices. So exactly the same product being sold for a variety of different prices across the NHS. And it indicated to them that there was an opportunity to adopt a transformation program in respect to procurement, and that the cash releasing savings potential of that transformation program could realize as much as 2.4 billion in 5 years investment, which could be put back into frontline services. And the background to this will come as no surprise. You know, as David has outlined, the NHS is an enormous organization. So it has the potential, by aggregating purchases and collaborating, to be able to drive a huge purchasing power on a national scale and deliver excellent value for money for NHS trusts and the tax payer. So if we move on to the next slide, we can see here one of the biggest problems that they noted was the fact that originally it was intended that as close to 100% of purchases would be done through the NHS supply chain. But what they observed was actually that 20% of NHS trusts were continuing to locally procure products and enter into local contracts, that 40% of procurement was traditionally done through procurement hubs, and therefore only 40% of the total NHS purchasing was done through supply chain. And it was felt that therefore that the NHS was unable to leverage its buying power, that there continued to be this fragmented supply chain, which led to this high degree of variation in product pricing and question marks over the role of clinical evaluation and assurance, and a landscape that was more complex than was originally anticipated, combined with competition for procurement resources and perhaps an excess of procurement resources. So if we pull all that together and we look at the next slide, then we can see how we can move from the existing operating model to what is now a category tower-based system with NHS supply chain controlling not only the logistics, not only the category towers themselves, but also providing a key and essential management function, transactional services, and a range of supporting technologies. So the majority, and as originally stated, as close to 100% of NHS procurement would be done through the NHS supply chain. Next slide, please. And so this is how they've reorganized those category towers. And again, our guidance is that you look at where your product relates within those towers, and then you make direct inquiry via website or directly to the NHS supply chain in order to identify those that are managing it. The organization is an extensive organization. It has a high number of staff engaged. It's represented out there in the marketplace. So there are representatives of NHS supply chain selling NHS supply chain services on behalf of those suppliers that are contracted through the framework agreements within the various category towers. Interestingly, and I've just highlighted on the graphic because it's not obvious, but those of you that are involved in digital health technologies, that's actually managed by Crown Commercial Services, CCS, under Tower 9, which is the office environment. And interestingly, that's a non-medical category. So quite unusual. I think it was really a bit of a short-term fix before I think they can properly integrate it into the medical category towers. But for now, office equipment is the category within which all digital health technology procurement is managed. Next slide, please. So as David alluded to, where do the opportunities exist? And I think we all know, and the same applies in Catalonia as elsewhere, that the consequences of the pandemic are now driving healthcare demand. So we've got the highest waiting lists that we've ever seen. So there's a big priority on procuring, acquiring technologies that are going to alleviate those waiting lists and help to manage down those waiting lists to what would be deemed reasonable and acceptable. The other thing we should consider, which we have on the next slide, is the NHS long-term plan. And we've given a link here so that you can go directly to that plan. It's important that you understand that plan and that you relate the benefits of your product to the context of the NHS long-term plan. And just in brief, on the next slide, we'll see that it is very much a birth to death plan, looking to make sure everyone gets the best start in life, delivering world-class care for major and chronic health problems, and supporting people to age well. It talks specifically about doing things differently, so a high emphasis on innovation, and it also talks about the value of successfully transitioning toward the utilization of digital health technologies. And as David alluded to, with the integration of health and social care, there's a requirement in order to connect those two systems that's done using a variety of digital connectivity. So a great opportunity if you're involved in digital health technologies. Next slide, please. So I think we'll move to the next slide in the interests of time. So really in this slide, and it's not deliberately complex, this is the graphic taken directly from NHS documentation, but it shows here, when we look at the adoption of innovation, that it's highly complex, involving a lot of stakeholders. So I think you're going to have to spend some time really looking into this, and this is something that as an organization we support, but knowing the different stakeholders, knowing how to connect with organizations like Health Tech Connect, which is an online repository, if you like, of new health technologies, being able to work through organizations like the Academic Health and Science Networks, work with programs like the Accelerated Access Collaborative, and be able to manage those interactions to the point where you can translate that into adoption is complex, but within this graphic there are some practical keys to how that process is managed and how you'll be able to access those various initiatives. Next slide, please. So really, final slide that I want to cover, we mentioned some of the drawbacks for the NHS supply chain framework agreements. And we know, particularly for digital health technologies and for innovation, that they rapidly iterate, change, and therefore there needs to be a more dynamic procurement system. And that's been created now through the dynamic purchasing system, which is in essence an electronic marketplace. So people can apply for and enter those dynamic frameworks much more easily than they can with the traditional framework agreements. And organizations like Spark, you can look that up online, will be a good example of an organization that's now successfully managing a dynamic purchasing system. For those that provide cloud-based services at the moment, G-Cloud 13, which is the government digital marketplace for those services, is open. It opened on the 9th of March. Applications close on the 14th of April, and that will secure you a place on that framework agreement for a year. And it opens and closes each year for supply in the following year. And in addition to that, NHSX, which is now integrated into NHS Improvement and NHS England within the Directorate of Transformation, have produced a whole range of guides, some specifically looking at topics like a buyer's guide to AI, some looking at particular levels of standards. Again, something I would recommend that you look up online and certainly look to take advantage of in looking at the best ways to access the NHS. Thank you.
Thank you, Neil and David, for your excellent presentations with very interesting market insight for companies aiming to access the UK market. We have already some questions in the Q&A chat. So we are going to start in a few seconds with the Q&A session. Para la audiencia, ara obrim el torn de preguntes. Si teniu algun dubte sobre el servei o voleu fer alguna altra pregunta, algun dels ponents, ara és el moment de fer-ho. Intentarem respondre a totes les preguntes, sobretot les més genèriques, les que veiem que són una mica més particulars, potser les respondrem a posteriori de manera més particular durant els propers dies. Oscar, do you want to start with some of the questions?
Yeah, sure, lady. Neil, David, I don't know if you already saw like some of these questions on the chat. Maybe we'll start by a couple of questions that are more on the general view. And the first one for me would be like about the constant elephant in the room, which is Brexit. And the question is like whether Brexit has affected the demand on products or technologies, especially the NHS, you know, and how. If there's like been a regionalization process, so is there like any affection on that side that you would like to highlight?
Yeah, I think one of the things that I mentioned was standards. So clearly, by exiting the European Union, we've decided to apply our own replacement for CE. So anyone wanting to sell to the UK from June 2023 will have to comply with UK CA. But in the interim period, then if they already have a CE mark, appropriate CE mark for medical device, then they're able to sell freely onto the UK market. But that's a change that people need to plan for. There is a scarcity of resources generally within the notified bodies and testing houses. We all had to reconcile with that when we were considering the transition from the Medical Devices Directive to Medical Devices Regulation, which is a European regulation. The indications are that actually most parts of UKCA mirror the Medical Devices Regulation and the in vitro diagnostics equivalent, the IVDR. But that to me would probably be the most significant change and challenge. But I think government has been quite generous in allowing sufficient time for companies to transition from one system to the other. Other than that, there are no real barriers. In fact, there's active encouragement. As David said at the beginning of his presentation, we're finding we're doing more and more work with established overseas companies that want to access the UK healthcare market, and that is being encouraged. So I think it's really the question is answered best in terms of challenge within that regulatory question.
Mm-hmm. Well, I believe that also answers one of the other questions, which was about like what's leaving behind the CE mark in next year. And also that my leaders are as well to ask about something that you mentioned, which is to clarify the name of the safety standard for digital products, in addition to the
so that's quite important. I think, you know, every country has its version. In the UK, it's known as the Digital Technology Assessment Criteria, and it encompasses really those key questions about connectivity, because what we don't want, well, connectivity and safety, what we don't want is a situation where products are adopted and it's used, but it won't connect. You know, you've seen from David's presentation the importance of integration with the integrated care system managed by integrated care boards. And, you know, at the moment we have an incredible diversity of product used across primary care, so with general practitioners, secondary care. You know, some of the dominant providers are quite different. You know, we've got EMIS in primary care, we've got Cerner or Epic in secondary care, and then we've got completely different providers within social care. So an important element of those assessment criteria is how well do products connect, and you know, that's governed by compliance with HL7 or with FHIR. So there are all sorts of key questions, but again, you know, I'd advocate people look those up online. You know, there's no secret about them, and they'll be able to see exactly the sorts of questions that are being asked that make up those criteria, and they'll be able to look at, you know, what they're perhaps already complying with within Catalonia and how that relates to the requirements within the UK. And I wouldn't think that they will be too dissimilar, because we're facing very much the same kind of questions. We're all trying to do very similar things. We've all been through exactly the same pain in terms of the pandemic. So it's just degrees, I think, but there will be a commonality between what people are doing in Catalonia and what people are doing, would have to do in the UK.
Thank you, Neil. We also have like kind of a super question, which is like pretty much like 3 questions. One.
3 questions in one.
From Aleix.
So there's a Aleix is asking a question about like the process to start a validation process for an app within NHS. It's a CE mark app so far, and well, he got a phone number. He wasn't able to contact, but I think like pretty much to understand that process. And again, like Lydia said, we can go also, we can follow up with the companies later if this is like too much to ask. So one part is this, to understand this validation process, to have this overview. The second is like how to get that clinical champion that David was talking about, and if having an MH area approval would have an impact on obtaining that clinical champion.
Do you want to do the first bit, Neil, and I'll talk a bit about the clinical champion?
Yeah, for sure. So I think so the question is, you know, what sort of validation processes are there? So there's a company, Orca, for example, that does a lot of assessment, and I think they become established as the NHS preferred assessor for digital health technologies, and the outcome of that will be a score. And so all scores above a certain level, I think it's 65 but don't quote me on that, because it has varied and it does vary. But there's a sort of a pass-fail score. And so if they go through that validation process and they're acknowledged by ORCA and the ORCA assessment, then they've gone through a validation if the question is specifically about digital health technologies. Often people sort of combine that with the appropriate regulatory requirements, because of course you can't sell to the market without being previously CE marked, in the future UK CA marked. So there's a number of sort of related validation processes. There's also, your compliance with the data protection requirements. So if it would help, we've produced, if you like, a checklist of what might apply, and you can kind of go through that checklist as almost like an aid memoir or a strategic or even tactical approach to that validation process. And I'm quite happy that we distribute it through our colleagues here in Catalonia, if that would help.
That's great, thank you.
So just on to finding a clinical champion. The best way is, if you already have somebody you work with, a clinician you work with in Catalonia or elsewhere, is to get them to talk to their colleagues. I mean, clinicians are international very often. They'll have contacts in the UK. Get them to find and make the introduction for you. That is the best way. If you don't, you have to do a bit of cold calling. But I think, it's back to what is your value proposition to a clinician? You have to do a bit of marketing of yourself. Why would a clinician want to work with you, want to partner with you? So you need to put together some sort of proposal which says, look, we are the best in the class, we are ahead of the game. We've got some trials already. We've worked with universities. You've got to put together some sort of agenda which will get clinicians interested. And remember, they are driven by prestige. They're driven by peers. So if you can offer them something that none of their peers have got, an advance in a research career, that is all to the good. I mean, you might have to pay them. But actually, once you've got your proposal together, that you have to do a bit of Googling. You have to go online, find out who the key opinion leader is in that particular area. And you'll find that there is always somebody who's publishing and standing up at conferences more than the rest. If you can find out whether they've already got links with companies, and they have, that's all to the good, because they are a bit more open-minded. Because there are some NHS clinicians, in fact, I would argue the vast majority of NHS clinicians are not interested in working with small companies. So you've got to do a bit of searching, try a few people, get your proposition together, and say, can we chat to you? Let's set up a call, let's set up a Zoom call. But don't give up, because it really is important for you to have somebody in the UK who will stand up for you, who has got the reputation, and who will talk to other clinicians. So it is really very important. But if you've already got a clinician in your country, start there.
I guess just to add to what David said, if you want to, you don't have that, or they don't have the contacts that, are going to work for you in the UK, there's a couple of organizations that you might want to go through. There's sort of intermediaries, but associated parts of this whole sort of clinical research process. So starting with the National Institute for Health Research, they have a clinical research network, and they will work with you to find suitable centers to test your product. And so they'll find the leaders in those fields, those that are able to get involved in whatever it is that you've developed a product for in terms of application. And they could be your best friend in terms of finding a clinical champion, or finding an institute or an organization that can undertake the clinical research on your behalf. And they're supported by an organization known as the Research Design Service. So you can also talk to them about how you might manage that whole process through the clinical research network. So that's another way, if you really are starting completely from scratch, and you don't want to start the process of cold calling, knocking on doors. There's an intermediary organization there that might be able to help.
I suppose as well, you might try the academic health science networks. So there are 15 of these, which are really funded mainly by the NHS to try and help bring innovation into the NHS. They vary in their responsiveness. Some will respond and others won't, but there are 15, and it might be worth looking at how they might help you. So that's the AHSNs.
Yeah.
And the last bit was how does the MHRA approval impacts on that clinician trust in the company?
So the MHRA, they are the regulator, and they've now more power than they had before when they were part of CE. Working with them, again, I wouldn't say they're a completely friendly face. I think, on average, questions are fired into them as an organization, and they could be, so I've developed a product, it's not UKCA marked. Can you give me some guidance, as to what might be its classification under UKCA? And response to that is anything from kind of 2 to maybe 8 weeks. So they're not hyper responsive. So many people go through a third-party advisory organization that can kind of steer them, set them up, if you like, for their interaction with the MHRA themselves. Another question, I guess, that occurs around MHRA is when you're undertaking trials or studies and you don't have a CE mark, or you don't have a UKCA mark. And so long as you've implemented a system, you're undertaking the processes to create technical files and so on, you can apply to the MHRA for what's known as a letter of no objection, which isn't a full regulatory approval, but it's sufficient to allow you to test your product in the marketplace. And that's often quite critical. So if you're thinking of accessing the market, you don't have the necessary approvals, you're still in development. How do you test that product under the regulatory standards? And so you pursue that by working with the MHRA to obtain this letter of no objection. So it'd be just a few sort of reflections. Otherwise, I think it's a direct contact with the MHRA to ask your specific question, and they will respond. They're bound to respond, but it's often, at least feedback we get, is that process can be quite slow.
Thank you. Lady, I know we are a little bit out of time. There's a question by Xavi Comas, which I think Xavier, makes sense that we can apply and
we can finalize with the Xavier Comas question, and we will try to answer the other two left. If you don't mind, is David, Xavi say thank you, David, for your recommendation. And talking about the opportunity in the private care sector, what do you think about providing on-site oral health at care homes, thanks to an efficient diagnosis platform and mobile dental units?
I'm not sure I got all that. I'm sorry. So, what was the question again? It was about care homes.
Yeah, oral health on-site.
Oh, okay. Dental. Oh, that's interesting.
Yeah, exactly.
I have no idea. I mean, at the moment, maybe Neil knows, but I do know from personal experience that the NHS dental support is reaching crisis point. It's very difficult to get free dental treatment on the NHS, and so in a care setting, I imagine it's even more difficult. It's a specific. I mean, I could probably find out because we work quite closely with a number of nursing and care homes, and I've never asked the question about. I'm afraid the old people's teeth. I have a horrible feeling that some of them don't have their own teeth, but some of them will, I'm sure. Do you know anything about that, Neil?
I think it varies by provider. I mean, as you indicated, it's a very ownership in social care is very diverse. You've got wide and broad ownership, and I think some of the high end will contract to dental practices under a private arrangement, which ultimately the patients themselves pay for. But the majority, I think, access dental services through the NHS as they access clinical services through the NHS. But again, as David said, a lot of the elderly, I mean, without going into too much detail, lose a lot of dentures, and it's quite problematic in the later stages of dementia. Doesn't really involve the dental services so much. So I think you'd have to do a bit of research, I think, just to understand exactly how it applies. But I would guess, without having done all the research, that the majority of dental services in the care home sector are provided by the NHS, and they're registered. The care homes are registered with that, and in a lot of cases prioritized, I think, by dentists for that. But it does vary care home by care home, is my understanding.
In any case, I understand like these type of doubts might come like during the sessions, like when the companies are already like part of the service, and they would be able to like get like more details from having direct access to you and our team in London.
Absolutely. Look forward to it.
So we can finish here the Q&A if you agree. Neil, David, thank you very much for your collaboration. It has been very interesting to come with you in this seminar. And now, para l'audiència, només recordar-vos que hem posat al xat l'enllaç on a partir de demà estaran les presentacions del dia d'avui i la gravació. També que teniu encara l'oportunitat d'inscriure-us al seminari de demà del mercat francès i que estan obertes ja les inscripcions per al servei a qualsevol dels 3 països fins al dia 22 d'abril. Qualsevol informació addicional que necessiteu, també teniu al xat les meves dades de contacte. Moltes gràcies a tots i fins aviat.